piece. All right, heart failure. We spent a lot of time on normal cardiac function last week, mostly so that we can spend a little less time doing it this week. I did kind of combine a whole bunch of pictures here to help you see the difference here. Again, we have the right heart. Is this taking my drawing? Yay, it's working. It's doing right heart, and we have our left heart here. And so I want you to think about these hearts being split in the middle with the lungs in the middle. These are the lungs. And our right heart receives venous blood, and the venous blood is coming from the vena cava, the intestines, the liver. Everything is getting processed through and then returning to the heart. Basically, the liver is the last stop before the heart, where everything gets filtered out before it gets circulated again. It's also where all of the contents from our intestines dump in, so nutrients and things. The liver filters them out, and going back to block 3. But basically, the stop before the heart is your liver. So when we have backup from the right heart, I want you to think into the venous side of the body, because that's what is returning to the right heart is venous blood. So venous blood returning to the heart is what we're considering our preload. All right. So then on the left side of the heart, that is responsible for circulating out into our arterial circulation. So I want you to remember, right heart gets venous blood, then it goes to the lungs, gets changed over to oxygenated blood, and then the left heart pumps it out to the body into arterial circulation. So I like these components because you can kind of see what the two sides of the heart are doing, and why we're worried about when there's right heart failure, we see certain signs, and when there's left heart failure, we see certain signs. So let's move forward to talk about the signs. So I do have these pictures kind of in small up in the corner here so that you can keep these in your mind, because it's really hard to memorize a long list of what happens in right heart failure. But if you know what it is getting its blood flow from and what happens when that side goes down, it won't be as surprising for you to help figure out the symptoms. You see edema, pitting edema in the lower extremities, because everything is backed up this way. So things are going to spill out of the heart into the venous circulation, and the weakest vessels in the venous circulation are at our capillaries, and our capillaries exist out in our extremities. So think about that blood will back up to our extremities. Blood backs up into the liver and spleen, so you get a swollen liver, and that's because blood's backing up that way. Blood will back up into the GI vasculature, so into the veins there, and that will send out the signal that you have a decreased appetite. You might get some abdominal swelling. You'll feel nauseous because those veins are full. Why would you get tachycardia? You just said that the right heart doesn't work. Any thoughts for why you get tachycardia? Nothing. Crickets, crickets. Crickets. So someone said low magnesium. That doesn't have anything to do with the cardiac blood flow here. And yes, because the heart is working harder to circulate this volume. The volume has gotten backed up here. The volume's all backed up here. What's getting out to here is a lot less. So what's actually getting circulated out to the body is a lot less, because it's all backed up on this side here. So what is actually being circulated out is a smaller amount, because all of it's getting held up behind there. Think of it really as a construction kind of site. So if you think about a highway, and they're doing construction on the highway. So let's say the right heart is where they're doing construction. If you have a 6-lane highway and you turn it down to a 1-lane highway, which is kind of what happens when you have all this right heart failure, that basically it was pumping through tons of volume, but now it's gone down to 1 lane. Well, the traffic backup will be back here. It doesn't mean there's less cars on the highway. It just means that all the cars are stuck behind the construction, and what does get through is much smaller. And so the heart will actually try to work harder to overcome and supply, because the heart's job is to supply the body with arterial oxygen, and it's not able to do that because the blood is backed up in this behind the side of the heart. It's not working well. So you do get tachycardia because the heart is working faster, trying to pump less blood through the body. That's also why you get hypoxia, because not as much blood is exchanging in the lungs. Shortness of breath with exertion, because you're not pumping out enough blood to the body. And dry lung sounds. Not enough blood is getting through here, so there's no edema getting into the lungs. It's just not enough blood actually getting changed over from CO2 to oxygen. So not enough blood is circulating through the lungs and then out to the rest of the body. The dry cough is just a reflex that when you're not getting enough oxygen, the body tries to clear its lungs. There's nothing wrong with your lungs at all. The lungs are working perfectly fine. They are actually just dry because the right heart isn't pumping much to them. Does that make sense? Anybody want me to stop on that concept? We basically just have all of our venous blood is backing up on this side, and it's not getting through to the lungs in the left heart. So what we start to see as things get worse is this backup getting worse. We will have jugular venous distension. The jugular vein is one of the veins that dumps into the right heart. So if it is backing up out here, then it will start showing up. The first vein that we will start seeing this backup will be the jugular vein. So when we have jugular venous distension, that is a sign that we are having worsening right heart failure. Edema in the lower extremities now getting bigger because we've got more backup, more push out of the vessels into the veins. Weight gain. And someone asked me a great question last week about why you have weight. Isn't it the same amount of circulation going on? Yes, you do. But what is happening over here in the arterial side at the kidney level? What is the kidney seeing? A lot of circulation or a little bit of circulation? What do you think the kidney is seeing there? They're seeing, hey, you're not pumping a whole heck of a lot out to me. So what does the kidney send out when it doesn't get enough blood flow? Oh, that troublesome system that you learned about in Block 3 and you thought you were never going to have to hear about again. Unfortunately, the kidneys are upset. They have low blood flow. They don't know why. So they send out renin. And renin increases the blood pressure and increases the retention. That's supposed to be fluid retention there. I can't scribble that fast on the thing. So the problem is that the kidneys are trying to help themselves, but they're not really looking at what's going on north of them. They're just taking care of themselves. And they're like, you're not getting me enough blood flow, heart. So guess what I'm going to do? I'm going to help you out here. I'm going to give you some renin. I'm going to hold on to some fluid for you. And the heart's like, yeah, gee, thanks. What the heck am I going to do with all this fluid? It's already backing up. Well, just add it to the pile. And guess what? You end up with more edema, and it's all in the tissues, and it's still not circulating through the heart. So the kidney's like, dude, I thought I gave you more fluid, but you know what? I'm going to give you more. And so you keep retaining fluid because of the kidneys' over-involvement in the process, and you keep retaining fluid, and it keeps getting pushed out into the tissues. So you have worsening and worsening and worsening edema, peripheral edema. You do not have lung edema with right-sided heart failure because nothing is getting through the right heart to even get edematous into the lungs. So your peripheral edema gets worse and worse and worse and worse, and the kidney keeps holding on to stuff, and worse and worse and worse till you finally have legs the size of an elephant, and it's because your heart can't handle the amount of fluid going through it. So worsening edema and the weight gain comes from the fact that your body just keeps retaining fluid and it keeps getting pushed out into the tissues. You have shortness of breath at rest. Why, if you're sitting on the couch with your large elephant legs that are all swollen, are you short of breath? You're short of breath because there's not enough oxygen pumping through the lungs to get oxygenated. All that blood and all that volume and all that fluid is in your elephant legs. It's not in your circulation, and so it's not getting oxygenated. So you are short of breath, but when you go and listen to the lungs, there's nothing wrong with the lungs. They're clear as bells. And why would you get renal failure? Because of this consistent low blood flow. The kidney keeps increasing its fluid retention, and then it never sees any results from it. It's all in the tissues. The kidney just finally will start to fail because of the low blood flow going out to the bottom. So that is worsening right heart failure. Any questions, or do you want clarifications on what we're seeing in right heart failure? So when you think of right heart failure, think of blood back up to the venous extremities and think of dry lungs, okay? Dry lungs, a lot of peripheral edema, a lot of venous edema. I'm going to leave that scribbles, and we'll go on to the key assessments that we're looking for. So if we are worried about venous edema, we are worried about looking for signs of fluid overload, which are edema, JVD, and the swollen liver and spleen. We are not worried about lung edema because the fluid just isn't getting past this heart. Oop, go back. The fluid isn't getting past here. That's under construction. It's not working, whatever reason. And so we are not getting lung edema in right heart failure. It's not listed as part of fluid overload. It's all tissue edema. Perfusion is going to be decreased. We're going to have, what's going to happen to your blood pressure and your heart rate if your perfusion is decreased from right-sided heart failure? What do you think your blood pressure is going to do? Any ideas? I'm getting a cricket noise on my phone. So your blood pressure, you think it will vasoconstrict. Your blood pressure will try to fit around the less amount of volume. So you will vasoconstrict, but you don't have a whole lot of volume in there. So it might not change. It will probably either, so people are like, well, if you don't have any volume, I'm going to drop your blood pressure. But we have a vasoconstriction that's trying to happen. So if you have an arterial blood vessel, and you only have a little bit of fluid in it, so we're just putting a little bit of fluid in there, it will vasoconstrict down to maintain a pressure. And so that vasoconstriction will not show up as high blood pressure. It shows up as normal blood pressure because it is vasoconstricted down to just maintain pressure in that vessel. So it won't really drop out because we still have vasoconstriction going on. And really your pressure is when the vessel wall is basically full of fluid is what your pressure is. So we're not over full of fluid. So it might increase. It might just stay normal. It might drop depending on how low the blood flow is. So the blood pressure really isn't going to really tell us right then and there, oh, our blood pressure's high, we have right-sided heart failure. Oh, our blood pressure's low, we have right-sided heart failure. Your blood pressure may not change, but you do have decreased perfusion. So let's look at other things for perfusion. But what we will see increase, so we're saying we're not really sure what our blood pressure will look like, but what will happen is our diastolic blood pressure will go up, because we are vasoconstricting. So your systolic may or may not change, but your diastolic blood pressure will go up because we're trying to constrict around that, that less blood fluid. Our heart rate will go up. That will increase. And our EKG will just be really tachycardic at this point because the heart's just trying to work hard. What do you think our pulses will be in a low blood flow state? One or two people. They will be diminished. Your pulses will be diminished or weaker because you don't have as many, you don't have as much blood flow flowing through. So even though your blood pressure may be staying somewhat normal, your heart rate going up, your pulses will be a little bit weaker. Your skin color and temperature could be paler. Because you are not perfusing as well. Your urine output will eventually go down, and it will go down for two reasons. because it's retaining fluid, because it thinks it needs more fluid, or because you're having renal failure. Oh, I put urine output twice, probably because I wanted to talk about the two reasons. This would be fluid retention. So it thinks it's dry, and so it's holding on to fluid. And it's also could be questionable renal failure. And going back to block 3, what kind of renal failure would it be? If you went into renal failure from right heart failure, low blood flow, what kind of renal failure would it be? Oh, look, you remembered. I'm so proud. It would be pre-renal failure. Low blood flow to the kidney gives you pre-renal acute kidney injury. So right heart failure can give you some renal failure as well. So just to kind of give you the whys behind your list here, oxygenation, what would happen to your oxygen saturation? What do you think? So you think it would be low, but actually it's usually 100% because the blood that does get to your finger is 100% saturated. It's just not a lot of blood. So I would say it would be normal. So you may have a patient that is huffing and puffing, and you put on the pulse ox and you're like, oh, you're 100%, you're fine. It's because the heart's failing. It's not a lot of blood flow, but what blood flow does get to the lung gets exchanged beautifully. There's no pulmonary edema. There's no bad lung sounds, and you're saturating normally because the low blood flow that is flowing to the heart, through the lungs, it's all exchanging perfectly fine. So the blood that does get pumped out is saturated. So, and what we're reading on the pulse ox is your arterial blood flow, and it's 100% saturated. It's just not a lot of it. So your oxygenation, you could be blowing off your patient. They still are short of breath. So, oops, let me go back. I didn't want to draw there. Shortness of breath is happening even with good oxygenation. The lung sounds are clear. So this is the patient that's very similar to, what other thing have you learned about in block 2 that has clear lung sounds? Well, that one doesn't have good oxygenation though. It's like a PE. And a PE is kind of the same deal, that not a lot of blood flow is getting to the lungs to get oxygenated. Here we have just not a lot of blood flow, but it is oxygenating just fine. There's actually no problems going on. It's just less blood getting oxygenated. So your body is short of breath because there's not enough oxygen to provide it with its jobs because of the low blood flow through the lungs. But there's actually no problem, and that's one of the quirks about right-sided heart failure is your patient's like, I can't breathe, and you're like, but your lung sounds are good and your oxygenation is good, but they are huffing and puffing at you because it's not enough to provide the body with the oxygen that it needs to do its jobs. And so signals are going to the brain saying, breathe faster, get more oxygen. The whole problem is associating and starting in that right heart. So clear lung sounds, your oxygenation is probably okay, but you're having other problems going on. Your lab work that you're going to get on a patient like this, if you suspect any kind of heart failure, is a BNP and an EF. Those are our big, and I love the BNP there, breathing near impossible. Because BNP means that your heart, if you have a higher BNP, that means your heart has had damage to it and is probably in failure of some kind. And you'd have to look at the ejection fraction. And the reason, what do you think would happen to the ejection fraction here? It's not because the left heart is broken. It's because it's not pushing out, it's not getting a whole lot of volume. The ejection fraction could be less than 40. It could be perfectly normal. If it's only getting, the left heart, if it's only getting 100 milliliters when it's supposed to be getting, that's probably not a good, that's not what fills our ventricle. Our ventricle is usually probably only about 50 milliliters. Let's say it's only getting 10 milliliters in that ventricle, and it squeezes out all 10. You have 100% EF, but you're still not providing enough volume to your body. So the ejection fraction, we're going to say less than 40 just because that is the thing for heart failure, but there's always one person that reads through the book and gets confused because it says that you can have normal ejection fraction with right-sided heart failure, and that's because there's nothing wrong with the left side of the heart, and that's where they're reading ejection fraction is from the right side of the heart, or sorry, from the left side of the heart. They would have to do a specific right versus left ejection fraction to figure it out. The right side of the heart is not ejecting all of its volume. It's just got a ton of volume. And so the right ejection fraction is low, not the left. So that could be something that maybe if you're looking at a chart and you're like, but the ejection fraction looks normal, and you said it was going to be less than 40, it's less than 40 on the right side. So if they're only reading left side ejection fraction, that one could be 100% normal. So what do I want you to pull out of right-sided heart failure? I want you to really pull out the important things are the fluid overload. That's the big one. And I want you to pull out the dry, the clear lung sounds. So those are the two that I want you to focus on for right-sided heart failure. Is the first things you're going to see. All of the changes in blood pressure, urine output, all those things, the body will compensate for a while. The first signs of, so let me clear all this and circle. The first signs you're going to see of right heart failure are going to be shortness of breath with clear lung sounds and fluid overload. So it looks like you should be having wet lung sounds, but you are not. So those are the things I really want you to pull out of right-sided heart failure. Any questions? Yeah, clear as a bell, right? Let's look at the left side now, and then here's, kind of a little summary slide if you like picture slides. But all of those things they do go along with what we kind of talked about. They just don't have real, priorities, like which one do you see first and stuff like that, which is why I like to tell you what you're going to see first is you're going to see the volume back up. So what you are going to see is the distended jugular veins, the edema, weight gain. If you've been watching the weight, the enlarged liver and spleen, those will be showing up first. And then we'll start to see the shortness of breath and stuff like that as the body stops to compensate. So anorexia and complaints of GI distress, that is going to be very vague. So I'd really rather you focus on the edema and the jugular venous distension. Those are your real big cues of right-sided heart failure. It's called cor pulmonale because after a while of being in right-sided heart failure, the lung blood pressure actually goes up trying to constrict. You end up with pulmonary hypertension out of right-sided heart failure because the lung vessels in the lungs start getting too vasoconstricted to work properly and exchange blood properly. But anyway, right-sided heart failure, mostly swelling. Sorry if I'm going too slow. I just want to make sure this is clear for you guys. Left-sided heart failure. So now we're putting our construction over on the left side of the heart. So if we have the heart having trouble getting blood through or it's not pumping well, guess where it's going to back up? Oop. I know you're all yelling out at home. You know exactly where it's going to back up, right? It's going to back up into our friends, the lungs. Okay? Lungs have a ton of blood vessels in them. You can see how tiny and narrow they are. They're only 1 cell thick. They're also very permeable. So as pressure builds in here, then fluid will escape into the pulmonary alveoli. So as blood backs up here, or as the blood flow backs up, it fills these lungs. What is happening on the right heart and is that it's pumping through what it receives perfectly fine, and it's pumping through just fine, but eventually we reach a point where these lungs, they're pumping blood into the lungs and they're getting back up. The lungs are very much suffering under left-sided heart failure because they are getting blood flow from the right heart and they're getting backup from the left heart, and the lungs are where this is all happening. So tons and tons of pulmonary edema in left-sided heart failure. Does that make sense? Not as much eventually over time, after left-sided heart failure has been going on for a long time. Now this backup, you filled up your lungs and it will back up the rest of the way. There will eventually be a 15-mile backup, but in the meantime, everyone gets off into the lungs. All the right heart blood is still being circulated to the lungs, the left heart blood is backing up into the lungs, and the lungs take the hit. So we see lung problems first with left-sided heart failure. So what we'll see first in right-sided is venous congestion and JVD and peripheral edema, and you'll have shortness of breath, but you will not have as much, you will have dry lungs. In left-sided heart failure, we have wet lungs. So the blood is not pumped through the left heart, it backs up in the lungs, less blood is becoming oxygenated because now your alveoli are full of fluid, and of course now we still also have decreased output to the body because the heart's not pumping anything through. So this one's a little bit more troublesome, and the one that you're probably more familiar with because this one has wet lungs. And it's left-sided heart failure that has wet lungs. Wet cough, crackles, that's just because we can't really control this exodus from the blood vessels into the alveoli. So we expect them with left heart failure to have a wet cough, some crackles, some wheezing, and that is just basically air in the alveoli. We expect them to have trouble breathing. Orthopnea means they have to sit upright to sleep, or they will actually label it. How many pillows do you need to sit upright to breathe? And what's happening is when you sit upright, let's draw a little person with some lungs here. So he's sleeping up on 2 pillows here. If we look at his lungs, where's the volume when you're sitting upright in his lungs? Where is fluid accumulating? Is in the bases here. Ooh, that actually looks, sorry, that is not drawing well. Let's not draw a little person. Let's draw your lungs sitting upright, and let's draw your lungs laying down. So when you are sitting upright, and I'm going to change this to fluid, when you are sitting upright, the fluid is kind of at the bases, and you can still have air exchange in the tops. When you're laying down, the fluid is kind of throughout the whole entire lung, and the air can get in, but it just can't get in quite as well. So when you're laying down, the fluid is bathing out your entire lungs, and when you sit upright, all the fluid drops to the bottom of your lung space, and you aerate a little bit better. Does that make sense? So what people will do is instinctively sit up. They have a constant cough, it is wet, and they have crackles and wheezes. So if you're listening to your patient in left heart failure laying in the bed and they are laying flat, you are going to hear your crackles and your wheezes on the posterior of the lung. If they are sitting upright in bed, you're going to hear it at the bases of their lungs because that's where the fluid goes. Fluid is just gravity dependent. So they feel better and can breathe better sitting upright. These are the patients that sleep in their recliners because they cannot sleep in their bed without having shortness of breath. You also get tachycardia with left heart failure because remember, your brain and your body are still asking things of your heart even though it's failing, and it will increase its rate trying to get flow out to the body. Just like in right heart failure, you have tachycardia in both. It's not specific for one or the other. What is specific is your jugular venous distension and dry lungs in right heart failure and your wet lungs in left heart failure. Here they are also, they're not oxygenating well. Whereas in right heart failure, all the blood that did get through is being oxygenated. Here we have fluid in our alveoli, so things are not oxygenating well at all. So that is the problem that we're having here. Now we're having trouble. We are having hypoxia. They will be using oxygen Whereas in right side failure, they're having shortness of breath because they're not getting blood flow enough to oxygenate for the body. In left heart failure, they are having shortness of breath. So both of them have tachycardia, both of them have shortness of breath, but for different reasons. In right heart failure, they don't have enough blood flow to supply oxygen to the body, but everything they're getting is 100% oxygenated. It's just not enough of it. And left-sided heart failure, they're having shortness of breath because they are not oxygenating well at all. The alveoli are filled with fluid, and it's hard to get the oxygen across the fluid membrane to even transfer your carbon dioxide to oxygenation. So shortness of breath with exertion, we kind of expect because you have a lot of fluid in your lungs. How do we know it's getting worse? Well, now not only, so let me kind of clear this all out again. So before, what we are seeing pop out into the lungs, let me just keep this thing, is fluid. So when this is all backing up, fluid is getting into the lungs. As the pressure gets worse and worse and worse, actual red blood cells start transferring across the membrane because there's so much pressure. It can't be even handled. And we actually are having red blood cells, which should never cross into the alveoli. Actually, the pressure is so high in there that you end up having red blood cells cross into the alveoli. And so what you're coughing up is now not just fluid, but fluid and blood cells. So it turns into pink frothy sputum because you have so much fluid. You are just basically they're trying to remove this fluid from their lungs by coughing it up. Paroxysmal nocturnal dyspnea is a specific cue that means that you wake up feeling like you're drowning from sleep because you are physically drowning. You are drowning your lungs. Instead, when you are in stable or controlled heart failure, your lungs here, sitting upright, were only filled at the bottom. And that relieved enough pressure. But now your left heart failure is getting so worse that now your entire lungs are filling with fluid. And that is known as paroxysmal nocturnal dyspnea. And the reason being, you are at sleep and at your lowest oxygen needs, and you cannot oxygenate your body. So your body wakes you up and you are physically feel like you are drowning. It is probably one of the scariest feelings people have said they have, is to wake up out of sleep and not able to catch your breath. And it's not because of closed airways, it's because of actual fluid in their lungs. They can't even get a cough going. And when they do cough, it's full of fluid and blood. You can imagine how scary that is. So paroxysmal nocturnal dyspnea is basically a very worsening cue of left-sided heart failure. And it does mean that the lungs are full of fluid and you are physically drowning. You physically have so much fluid in your lungs you cannot oxygenate. Decreased blood pressure because now the left heart has failed so bad that your EF is so low that you cannot put enough blood into the bloodstream to even with vasoconstriction, there isn't enough blood flow in there. Dyspnea at rest. Normally we will have dyspnea if we try to do something, but now we're having dyspnea at rest. Oxygen requirements are increasing. They're filling up their lungs with fluid, and everything's kind of going bad on that side. So I really want you to pull apart out of here. The first things that you are going to see is the wet lungs. Okay, in right heart failure, you will see jugular venous distension, peripheral edema, and dry lungs. In left heart failure, you will have wet lungs. So that's separating them out. If you can separate now some people have right and left heart failure, and you see all the symptoms. You see peripheral edema and wet lungs. That would be a combination. Is acidosis ever involved? So acidosis will happen anytime you don't have enough oxygen to a system. So acidosis could be involved with worsening conditions of both. Because when your body doesn't get enough oxygen, so I'll just write on here, acidosis is due to hypoxia. And if we think about when you don't get enough blood flow, decreased oxygen Doesn't mean that the body has to stop doing its functions. So when you have a decreased oxygen level, your body will increase oxygen via via what it's called anaerobic metabolism, which gives you lactic acid. So when we create energy from oxygen, that's a pretty clean process. It's like natural gas, very clean, no emissions, okay? So we still need oxygen, but we still need energy, but we don't have oxygen to make the energy. So they switched to a dirtier form of energy production, which is called anaerobic respiration. And that's what these cells are doing, because the cells have got jobs, man. Your whole body, there are cells that have jobs. Your kidney has to work, your liver has to work, your muscles have to work. And when they get plenty of oxygen, it's all clean process. When they don't get oxygen, they turn into getting their energy kind of a dirtier way, and that has emissions, and the emissions is lactic acid. So, and you can have lactic acid when you work out, and that's basically because when your muscles are asking for more oxygen than you can give it, then it will still you're still making those muscles work. You're making them run the marathon. You're making them climb the stair stepper. You're making them lift weights. You're making them do whatever you're asking them to do. And they need more oxygen than you can breathe in, even though you're huffing and puffing. The muscles are like, we're working way harder, man. So they start going to, all right, we're going to use all the oxygen we got, but then we're going to create energy and do our jobs via anaerobic, and that produces lactic acid. So whenever you overextend your body needs to the oxygen that's being delivered, it will start creating lactic acid. And so when you have hypoxia, your acidosis is due to lactic acid. So yes, long explanation for a short question, is acidosis ever involved? Yes, whenever you start getting hypoxic, acidosis does get involved. So if you keep increasing lactic acid, your body can become overwhelmed with those acids in the system. So good question. So yes, right and left heart failure can cause an acidosis if it's severe enough. So what we are looking for in your key assessments is, now we are looking at lung sounds and oxygen saturation, where we said, they're dry and right-sided, and your oxygen saturation could be 100%, and left-sided they are not. The lung sounds are wet, there's crackles, there's edema, and the oxygen saturation is decreased because you actually have fluid in your lungs. So does that make sense? Everything else should be very similar in right and left heart failure. So I find it's very hard to memorize a list because there's so many of the same symptoms on both of the lists. So I like to point out the differences. The differences in left side are wet lungs, on right side dry lungs. I could have just said that and just be done with it, but I don't think that's fair for you guys. You need to hear the differences and why, I think. Or you can just skip through it when you re-listen to the lecture. All right, so now that we know what it looks like, how do we treat it? We're going to talk a little bit about acute versus chronic, just like when we talked about our liver and our kidneys, we talked about acute versus chronic. We'll talk about acute first. Both of them have the same steps to treatment. We just use different things for that treatment. Abrupt heart failure is basically an abrupt onset. Usually due to an MI, pulmonary embolus, like basically you have no risk factors and you just all of a sudden have a failing heart. So things that put an undue stress on the heart, like basically killing its muscle with an MI, that puts a lot of stress on a heart, and it does fail pretty frequently after an MI. Pulmonary embolus puts a lot of stress on the right heart, can cause right heart failure because all the blood flow is blocked to the lung. And so the right heart's trying to push against it and ends up dilating out very rapidly. We had right heart failure after pulmonary embolus. Cardiac infections can cause the heart to fail because the muscle's actually infected. Anaphylaxis causes the heart to fail because you're having massive edema and stress, and of course really, really bad hypertension. So there are things that cause the heart to just fail abruptly. Then we have chronic heart failure, which develops over years and years and years, and there are so many different kinds. But this is slow, progressive changes, and it's usually due to, I would probably move this down on the list. MI with permanent damage, we're going to kind of move that down on the list. Most of the causes are hypertension. This is the #1 cause of chronic heart failure, is hypertension. Sclerosis of the aorta causing increased. What do you think all of these things, hypertension and our aortic atherosclerosis, will increase our afterload, which is what the heart has to pump against, and pumping against pressure for a long time will cause failure. If you actually have damaged your vessels or your valves, that will cause heart failure over time, depending on which valve is involved, which we'll talk about in a little bit. Cardiac infection, if it's slow and progressive and it takes time for that infection, or it's a viral infection that keeps coming back, can cause failure. COPD can cause failure. And what kind of failure do you think COPD causes? Quick quiz. Which kind of failure would COPD cause? Chronic obstructive pulmonary disease. So this is where you already have fluid in your lungs. Yes, the people that said right, because COPD already puts a ton of pressure and damage to the actual lungs, and so the blood flow around it starts getting backed up. You have basically you end up with those barrel chests. You have a lot of pressure in your chest. That creates a lot of pressure to get volume into the lungs to perfuse, and so that starts causing right heart failure. COPD causes right heart failure. The fluid building up in your lungs isn't due to left heart failure. It's due to basically you're having a lot of increased lung pressures, and COPD doesn't have a whole lot of fluid. It's just basically that air trapping. And so that air trapping starts making those lungs expand, and then it's harder to push blood into the lungs. There's a lot of pulmonary hypertension with COPD, and so that backs up to the right heart. So COPD does right heart failure. But eventually, after time and COPD, bad oxygenation, it can damage the whole heart as well. But it usually starts out in the right heart. So anyway, there's that. Let's talk about chronic heart failure first, because it's a lot more common. There are two kinds, really, of heart failure. There's systolic failure and diastolic failure. So systolic failure means that the walls got stretched and thin and don't pump well during systole. So it can happen in the right heart, it can happen in the left heart, it can happen in both. So the ventricular muscle is very weak in systolic failure. And we'll talk a little bit about all the sounds, but systolic failure is a big floppy ventricle that does not squeeze well. Big floppy doesn't squeeze well. It's known as dilated cardiomyopathy. So when we talk about heart failure, cardiomyopathy, dilated, congested, all these words mean the same thing. Basically, we're looking at heart failure. This is dilated or congestive heart failure because your ventricles are big and floppy, and when they're big and floppy, they can't pump, and so you have systolic, or basically failure of contraction during systole. This is such a big, floppy, full, that the ventricles never eject, and so the ventricles have a lot of stagnant blood in them. There's a high risk of clots in stagnant areas. And we will talk about the S3 versus S4 sound. S3 is the sound of blood sloshing into a dilated ventricle. So this is the first kind of failure, is systolic, dilated, congested, whatever you want to call it, but it is floppy, thick, dilated vessels. Damage to the actual heart muscle from an MI can cause this. Infections of the heart muscle that actually destroy the heart muscle, and then, or you have a lot of backup into the ventricle over time. So this is basically a weak, congested heart, and that is called systolic failure. Then we have another kind called diastolic failure, and there's two kinds, of course, of diastolic failure, but this is a problem with filling, because it's what is happening during diastole is the ventricle is supposed to be filling. So what is happening is the ventricle doesn't get a lot of volume in, and so it actually tries to get stronger to create a cardiac output, but there's just not a lot of volume for it to work with. So this is for the ventricles can't fill. Not that they're big and wide and floppy, they just cannot fill. There is not enough volume in them. So they have a different sound, but the problem is this hypertrophic. This is due to a muscle growing stronger. So in dilated cardiomyopathy, the muscle is weak and cannot eject. Here, the muscle is actually strong. Look at that swole little heart there in the hypertrophic. He has strong muscles. That ventricle is all muscle. Look at the difference in the picture here. This is a hypertrophic ventricle. Look how much volume it can hold versus a normal ventricle. Let's say this is 50 milliliters. And now this big swole thing, it's kind of like, think about weightlifters who can't put their arms down. This heart has gotten this muscle so big that it can't even fill. Now it only holds 10 milliliters because the muscle takes up so much room. And what would cause the muscle to grow? Trying years and years of pumping against resistance. So anytime we've had high resistance or high afterload, so if you want to look at systolic failure, what makes muscles weak is having damage to them, basically. Just basically the whole muscle has been damaged themselves. Consider that muscle wasting, ventricle muscle wasting for systolic heart failure. So if we go back here, this is is muscle wasting. And we're talking about ventricle muscle. So this one is ventricle muscle wasting away, either due to damage or infection or just dilating in general. That is the muscle getting wasted. This is muscle growing. This is a super, super strong muscle. But unfortunately, it swells so big, it swells into making less usable ventricle. So that is the big thing that you would think, wow, having a strong heart is amazing. And it is amazing to have a strong, efficient muscle. It's another thing to build to the point that you actually cannot fill. And that is the damage in diastolic failure or failure to fill. It can't fill because there's just no more room. Okay, look how big and swollen that muscle is. And this is due to pumping against increased resistance for a long time. So pumping against afterload for a long, long time. Of course, high blood pressure, aortic, if you have a narrowed aorta, that's the main artery that we're pushing into, the heart will get hypertrophic after long times of that. If it's constantly pushing against a tight valve, it can't do it. And then COPD, that right ventricle gets hypertrophic trying to push fluid into this tight lung space. So both of them are failure, but one has a weak lung and one has a strong lung. The big takeaway from all this, and then restrictive is very, very rare. It's usually due to autoimmune disorders that cause deposits in the lung that keep the heart from actually contracting very well. But the difference between systolic and diastolic is really your ejection fraction. So think about, this is how much, when you look at ejection fraction, that's the fraction of blood that you pump out. So we're going to go back to look at our weak heart here. So here, let's say we put in 100, let's say this one's a little bigger. So let's say this one fits 150 milliliters of blood. If it's got a weak muscle, how much do you think it ejects out? The whole 150? This is like an old dried up kind of sponge, you know? Yeah, no, it's only going to pump out to the aorta, maybe not even half of it. And that gives you the low ejection fraction. So this one has a low ejection fraction. This one's definitely less than 40% because we're not pushing out, we're pushing out way less than half of our blood because it's so weak. The next one, though, if you're using ejection fraction as your only cue and you're not looking at BNP, both of them will have an increased BNP. The weak muscle has already stretched and thin and it's put out a high BNP. This muscle is getting stretched and swollen and some of this stuff is damaged. It will put out a high BNP. Both of them will show a high BNP, but this one, let's say if it's filling up with 50 milliliters, oops, I keep forgetting to write the pen number. Let's say this one has 50 milliliters in it. It's so strong, what is it ejecting out? It's ejecting out like 45 of those milliliters. So its ejection fraction looks pretty dang good. So this one can have a normal ejection fraction for quite a while. And so that's why they like to differentiate between the two, because EF doesn't always be perfect. So people can say, oh, I'm not in heart failure, I have a great ejection fraction, but they could be in hypertrophic and still having low blood volume. Both have 40 or 50, 45 milliliters getting out to the body, which isn't enough. The body's looking for 100 milliliters. And these are just random numbers, really, guys. I don't even remember what a normal stroke volume is. It's been a while. But both of these are producing not enough blood out to the body. So if the body is looking for 100 milliliters to be given to it, and it's only getting 40 or 45, this one has an amazing ejection fraction, but it's only sending out still 45 milliliters because it didn't fill. So I hope that makes a little bit of sense. Again, I'm not going to test you which one's which. I just want you to be able to understand when you hear these things on charts, that they have diastolic failure or they have systolic failure, that you have a little bit of an idea of what they mean. And again, I'm not going to expect you to be perfect, but if you have a normal ejection fraction, you can still be in hypertrophic failure. It's the one exception to our cardiac failure rule, but really what I want you to look at is the difference here. This vessel, or this ventricle, is holding quite a bit with each beat, but is only putting out 45 milliliters. So when we look at that, that is not even a 50%. Well, that's almost probably, what's half of 150? I can't do that. I don't even know half of one is 75. So this is a way low ejection fraction. If we have 150 milliliters in there and we're only ejecting out 45, we're probably at a 30. We're at 30% EF right there, because we had a lot and we're only pushing out 45 milliliters to the body. So that's considered failure. And then we look at this boy, and this ventricle, this tiny itty bitty little ventricle down here, only holds, oh, stop it, 45 milliliters. And we push out 40 milliliters. This one's actually performing just as badly. The other one pushed out 45 milliliters a beat. This one's only pushing out 40 milliliters a beat. So you're still in failure, even though the EF of this one is 90%, because it's pushing out 40 milliliters over 45. Does that make sense to people? The bottom line for heart failure is, what are you providing to the body? And that's why ejection fraction, it's usually less than 40%, will get you automatically a heart failure diagnosis. No problems, no ifs, ands, buts. Less than 40% gets you a heart failure diagnosis. But there is one exception to the rule, and that's that super strong, swole heart has a great ejection fraction, but it's still putting out jack nothing to the body. So it's still considered heart failure, even with a good EF. So if you're reading that in the book, or you're getting that on your UWorld questions, that does come up in NCLEX questions very often, and a lot of people get it wrong because they're like, no, Professor Garrity told us less than 40% is heart failure. There's one exemption, and it's the super swole boy, and that's because he can't fill enough to eject enough out. So really, I just kind of tell you that because I've seen it on multiple questions. And unfortunately, this one is the most common heart failure. So basically, the patient is getting not enough blood flow out to the body. And then when they look through on, when they do a cardiac echo, they can see, oh yeah, you might have an ejection fraction of 50%, but they also measure filling and things like that. So they can diagnose heart failure. It's not strictly less than 40%. I want you to remember that 40% because that is a diagnosis of heart failure. As soon as your ejection fraction drops less than 40%, you have heart failure no matter what. But there is one exception to that rule, and that is this hypertrophic guy, heart failure. So you'd have to look at other things to diagnose heart failure other than ejection fraction. And the BNP is one of them. They actually will do the cardiac echo and read it and see the thickened heart wall and diagnose the diastolic heart failure from there. So we've diagnosed it. This patient has had an x-ray, had an echo, had whatever, they've done their workup, and they have heart failure. If it's for a long, long time, you can have heart failure developing and you'll never even know you had heart failure because you are being compensated. And what happens is that the other body systems maintain perfusion. So let's say you're putting out 40 milliliters to the body and the body's looking for 100. So what happens when it doesn't get enough blood flow? We kind of already talked about it. The kidney is like, dude, I got you. You are not giving me blood flow. I'm going to retain some fluid. The brain says, ooh, it's a little dry up here, guys, a little dry. I'm going to send out antidiuretic hormone and tell you to hold on to some fluid. Whenever the heart is not putting out blood flow, the brain sends out the sympathetic nervous system gets involved and starts increasing your heart rate and causing vasoconstriction. All these things happen until the flow gets adequate to the body, and then everybody's happy. So what you will see is your blood pressure going up, your heart rate going up, and those are normal compensatory measures that your body's doing to try and get more flow to itself. So if you only put out 40 milliliters a beat and your body's looking for, so basically what your body's looking for is a nice amount per minute. Like it wants a certain number of liters per minute that it's looking for. And that's where if you did, you're not going to have to memorize it, but the heart's looking for 4 to 8 liters per minute to be provided to it. It's sitting back and saying, to run my functions, I need 4 to 8 liters per minute. So if you're putting out 40 milliliters a beat, and this is just an example, I'm not going to ask you to do this on the test, but if you're doing 40 milliliters a beat, and you're beating at 80 beats per minute, you are putting out, and these are just random numbers, what's 8 times 4? Oh, I'm bad at math. You're putting out 3 liters per minute, or 3,200 liters per minute, right? Does that math work for everybody? I think I did it right. I did it in my head. I'm not a math person. So this is milliliters a minute. So the heart's looking for 4 to 8 liters a minute, so 4,000 to 8,000 milliliters a minute. It's like, dude, that is not going to work. So what it does is it tells the heart to beat a little faster. And now it's still putting out 40 milliliters a beat, but it's now beating at 110 beats per minute. So now we are putting out, we're putting out 4.5 liters per minute. So the body's like, you're golden, girl. We're good. I'm happy now. I'm going to stop nagging you. So the tachycardia is not a problem here. We're just trying to get adequate circulation. Okay, so the tachycardia is a compensation measure, trying to get the body more. Now, if you were beating normally and you were putting out 75 milliliters per beat, then a lower heart rate is going to perfuse your body just fine. So I'm just doing these as concepts. I'm not going to make you do that math on the test, but I want to show you how the body compensates for having low output. 40 milliliters per beat's not great, but if the body jacks up the heart rate, then we get an adequate output. So I'm going to let you guys digest that for a minute. And this is what we do with a lot of failing hearts. We let them be a little bit faster. because the body's just doing what it's trying to do. It's trying to get that. And then it will retain fluid, and it may or may not see results from retaining fluid. It might pump up the preload a little bit and help the heart. But unfortunately, I love the Pikachu meme up at the top where the heart fails to pump blood to the body. And then the kidney's like, okay, here's some more. Heart pumps even worse. And the kidney's like, what? I love that picture. That's exactly what is going on. The kidney's like, what did you do? I just gave you some volume and you're not doing anything with it. So basically, that's what we're going to say. We don't mind seeing tachycardia and some fluid retention. We know the body's trying to compensate. What happens is when the body, the compensations get to be too much, or the heart fails even worse, that's when we start seeing the worsening cues. And so when we treat this, we are trying to help the body compensate or trying to fix the heart. So the first thing we want to do for either one, acute or chronic, is we want to increase the heart strength. Okay, we want to up that 40 beats per milliliter, or the 40 milliliters per beat. We want to have that heart kind of squeezing a little stronger. We're trying to get out maybe 50 or 60 milliliters per beat. So we're trying to make the heart stronger, and so the first step is they're going to get something to help them beat stronger. If it's long-term treatment that you're on, you will be on DIG. So almost every single heart patient is on digoxin because it's natural, it's all organic, it's from the foxglove plant. It's an organic material, and it basically increases the strength of heart contraction. So we love DIG. DIG works. Unfortunately, DIG is easily toxic and needs to be monitored pretty closely. But it's our only oral inotropic at this point. So our first line of therapy is to get this heart pumping stronger. We do have some IV inotropes. These were all listed in your hemodynamics piece, but the ones that help squeeze, or the ones that increase squeeze and increase your cardiac strength, are our favorites are milrinone and dobutamine. Those work right on the heart to get the heart stronger. Dopamine and epi will work on the heart to make it stronger, but they have a lot of other side effects with them, including increasing your blood pressure. So we may not use, those are kind of down on the list. When we just want the cardiac to squeeze, we're going to use something called an inotrope. So do not forget this word inotrope. Inotrope equals squeeze. And it is the main stay of heart failure treatment, is getting that heart to produce a little bit more with each beat. And our mainstay there for long-term care is going to be DIG. And for a quick burst, we can do IV. Maybe if this patient isn't handling their DIG very well, we can do quick burst. And this is our number 1 and number 2 choice. They're here, but they're kind of used as last resorts. I put them there because they are inotropes, but they also cause increased blood pressure. So we might not want a heart that is failing to have to pump against increased blood pressure. So we would rather use on sick hearts milrinone or dobutamine, which you may not have heard of yet, but they are our mainstay cardiac squeezers. But for most long-term patients, they will be on digoxin. So a little note about digoxin. Oh, NCLEX loves digoxin. NCLEX loves DIG toxicity. It is amazing. You will have to learn DIG. I would probably go ahead and learn your normal DIG levels, just less than 2. And anything greater than 3 is considered toxicity. The most important thing to learn is what I have already bolded and highlighted for you, that DIG toxicity causes nausea, vomiting, cramps, and diarrhea, which of course could be mistaken as a flu or a stomach bug, but then it also causes vision changes as well, causes blurred double vision and weird color vision. Vision changes are the 2 first causes. And then later on, as DIG gets toxic, it causes dysrhythmias and bradycardias. It basically alters, and that's how it works, is to cause increased squeeze and cause the heart to work a little bit harder. When it is toxic levels, it causes bradycardia, and then into, I know people are like, which one is it? Bradycardia, tachycardia, arrhythmias? Any dysrhythmia is on the table with DIDGE, okay? Any dysrhythmia. I have seen every single dysrhythmia in the world accredited to digoxin. So I would rather you remember just arrhythmias in general. It could be prolonged PR, it could be weird QRS, it could be VTAC, they have attributed every single rhythm under the planet to DIGE toxicity. So I know they like bad van and all these mnemonics. I would just remember any kind of arrhythmias could be a sign of DIGE toxicity. So we look at our first ones. Hey, have you been nauseous, vomiting, having diarrhea? Oh, I thought it was the stomach bug. Like, oh no, it's probably DIGE, especially if it comes with vision changes as well and arrhythmias, DIGE. But I would put any arrhythmias. I've seen AFib attributed to DIGE. I've seen PVCs attributed to DIGE. I've seen everything. So it's not just bradycardias and tachycardia. It's anything. Any abnormal heart function. If your patient's on DIGE, you should get a DIGE level. So those are the big ones. I'm just going to, you know what, change this for you right here. And we'll just write any dysrhythmia. So you don't have to remember. Look, I took that away from you. Any dysrhythmia when your patient is on DIGE should be, you should be checking DIGE levels. DIGE levels should be taken sporadically, just like if you're on an anticoagulant, you need to monitor your PTINR. When you're on DIGE, you need to monitor your DIGE levels. They should be getting their DIGE levels drawn pretty frequently. And they should be notified of what symptoms of DIGE toxicity are so they can report them to their doc and get a DIGE level. But the treatment for it is to basically stop DIGE, stop DIGE completely until the DIGE level comes down. Just like if you're bleeding on an anticoagulant, you would stop the anticoagulant until the PTINR returns to normal, and then put it back into the system. So basically we're treating arrhythmias and electrolyte imbalances, and DIGE and potassium go together. DIGE can cause hyper or hypokalemia. So any dysrhythmia and any potassium deficiency. You can have DIGE toxicity with hyperkalemia, and you can have DIGE toxicity with hypokalemia. So I want you to remember when you're thinking of DIGE, things that go with DIGE and things that we worry about with DIGE are any dysrhythmias, and it can happen in hypo or hyperkalemic environments. So you want to draw not only a DIGE level, but some electrolyte levels too to look at your potassium. So with DIGE, I want you to always did I write this somewhere? I don't know if I wrote this. Nope. So when you see DIGE on your patient's MAR, I would like you, if you're in a hospital setting, to monitor an EKG, monitor your potassium, and monitor for these signs and symptoms there. If they are having any signs of toxicity, I would want you, and the DIGE level. So any signs of nausea, vomiting, cramps, vision changes, even if they think it's the stomach flu, oh yeah, I think it's the stomach flu, why don't you come in, we're going to draw a DIGE level, potassium level, and look at your EKG real quick. That is really the takeaway from digoxin, is that because it can get toxic so quickly, anytime patients complain of nausea, vomiting, cramps, or diarrhea, or any kind of vision changes, like, ooh, I'm starting to see kind of halos around things, you need to talk to the doc, or if they're in the hospital, I would like to see that you get an EKG, a potassium level, and a DIGE level on any patient with those symptoms. Okay. So I think at that point, let's just kind of go through I'm not going to spend a lot of time on this one, and we're going to break for lunch in just a second here. So the first thing, again, is trying to get the heart to squeeze better. We have inotropes, so digoxin or milrinone or dobutamine if we need some. I just want you to be familiar with the names so that you recognize them as inotropes or squeezers. If we cannot get the heart to improve by giving it squeezers, like it's just done, it's not responding to digoxin anymore, it's not increasing its it's not helping it squeeze anymore. We try IVs, it's not helping them squeeze anymore. Then we have to do physical mechanical support. I don't need to know how these work. I just need you to know that the two forms of mechanical support for a failing heart where inotropes don't work is a balloon pump and a ventricular assist device. This is when the inotropes are no longer effective. We have to go to something mechanical. A balloon pump is something that is just temporarily inserted. It's an external device, and it helps support the heart by decreasing the afterload, and it actually kind of vacuums small amounts of blood from the left ventricle, so it helps pull blood out of the heart. And then the ventricular assist devices are physical ventricle replacement devices. They're physical mechanical pumps that can be put in to override the heart and provide an output. And these are where we have huge innovations with these that basically they're assuming that the heart is no longer going to be working when you're on this ventricular assist device. And these are kind of semi-permanent. And they're used as a bridge to transplant, or actually as what they call destination therapy, that maybe you won't need a transplant if we have a small enough ventricular assist device. It's basically bypassing, you can see they're put in permanently, that bypasses the ventricle and actually physically pumps for the ventricle. So those are the options when we cannot get the heart to work anymore with our inotropes. So first we're going to do medicine and then mechanics. But the first thing we have to do with heart failure is get it squeezing better. Most patients live perfectly well on digoxin, and that is the assist for getting an increased functional heart. Then we move it up to IV therapy, and then we move it to mechanical support. And these are just some pictures of the balloon pump and the ventricular assist device. Evan, I'm not going to ask you how they work. I just want you to know that a balloon pump and a ventricular assist device are the mechanical support that when all else has failed with inotropic support, we have to physically replace something that can do cardiac output. Then there's some surgical options as well. Most commonly is the cardiac transplant. And the other thing that we can do that has come out in the past few years is they can actually, for hypertrophic cardiomyopathy, where that ventricle has gotten so swollen from pumping against hypertension or a tight valve, that they'll actually cut off parts of that swollen muscle wall. Of course, you have to fix the underlying cause first, but then they can cut out that piece of and open up that ventricle for more filling. Again, it's pretty risky to cut out a piece of a ventricle, but that is a treatment that is an option. So there are surgical treatments come after the mechanical support. So that is our first tenet of any kind of heart failure, is get the heart pumping better. Okay, let me just go through the other two and then we'll go to lunch. The second thing that we're going to do is symptom treatment for the rest of the problems that are going on. So first thing we need to do, get the heart pumping better, because the body's going to keep asking things of the heart. It will never be allowed a break. It's like a mom or a full-time dad, or you'll never get a break. It just won't happen. The heart never gets a break. We can only support it. So we're going to try and get it to squeeze better. And then the other thing we're going to do is symptom treatment. We want to reduce the preload that's coming back to the heart so the heart doesn't have to deal with so much fluid. So we will give diuretics to any heart failure patient because we want to make sure that we're removing some fluid from the system. Most heart failure patients have too much fluid that their heart can't manage at all. And they're ending up with right heart failure. We're ending up with peripheral edema, peripheral edema, neck vein distension. In left heart failure patients, we're dealing with fluid in the lungs. Either way, a diuretic will work to get rid of that extra fluid. So most heart failure patients are on a diuretic. The other thing we'll do is a vasodilator, which is usually nitroglycerin. And that is something that will help keep those veins kind of dilated and keep blood from returning to the heart that we have to deal with. It does, basically opens up those veins and allows blood to pool in the veins a little bit. It also increases the size of the cardiac vessels and helps get the heart some extra oxygenation. So nitroglycerin is our preload reducer of choice that will help hide fluid from the body. we need to get rid of the fluid and then allow those veins to have a little bit of extra. So diuretics and nitroglycerin are on almost every single heart failure patient. The nitroglycerin is not necessarily heart pain treatment. It is being used as its vasodilator effects. And then we do have some IV vasodilators that we can use if they need to. They have IV nitroglycerin. So nitroglycerin is a mainstay of heart failure for its dilating properties. So diuretics, nitroglycerin, and then of course they will be continuing your antihypertensives. We got to reduce the afterload as well. So we are doing something with all three of our cardiac components that we talked about: preload, afterload, and contractility. We're giving DIG or some kind of IV squeezer or mechanical therapy or something to get our heart squeezing better. We're reducing preload with diuretics and nitroglycerin, and we're reducing afterload with an antihypertensive. Does that make sense? So that is heart failure treatment. And then, of course, we need to help our patient help us out. We're throwing all these meds on you with the purpose of relieving pressure on the heart, giving the heart a little bit of oomph, but we need the patient to do their job and stop smoking. That's going to be causing lung constriction. It's going to be causing vasoconstriction of the vessels, and we're trying to give you antihypertensives. We don't need you vasoconstricting things and decreasing oxygenation. Stop smoking. Heart healthy diet includes low sodium because we're trying to get rid of fluid. What the heck are you going to be eating sodium and retaining fluid for? No sodium, avoid excess fluid, avoid alcohol. Alcohol's a depressant, depresses the heart rate. Low cholesterol, low fat. We don't want more atherosclerosis going on. Getting out and exercising, but remember, if you exercise too hard, your heart isn't very good right now. We don't want to stress it. So low impact. We don't want to be starting to try and build strong heart muscle. We already have a weak heart muscle. We don't need to be going out and doing high impact aerobics or, heart rate training and things like that. Low impact walking. Walking is the exercise of choice for heart failure. Got to take your meds. Okay. They're all there for a reason. Preload reducers, afterload reducers, inotropes, take them. They're there to keep your heart from failing further. They keep you from going into worsening conditions of heart failure. There is a symptom tracker, which is amazing. It will help you study. Click on that and look at the symptom trackers. I love it. It's what they're going to teach patients about. So why would you not use it to learn? And then, of course, any worsening conditions are saying that your meds are not controlling it. We're trying to keep you in the compensated area. And any weight gain, extra peripheral edema, dyspnea on exertion. So if you were able to do 2 laps around the block and now you can't even get up and cross the room, that's worsening dyspnea on exertion. Worsening orthopnea, you know what, I sleep up on 1 pillow and now I have to use 4 pillows to breathe at night. I'm waking up in paroxysmal nocturnal dyspnea. I'm drowning at night. Those are worse. And any signs of digitoxicity. So here's the symptom tracker again. I think it's an amazing tool with visuals to show you existing and worsening cues. And then these are just a review of, I think this is what, I thought I had put it in the, I just need you to be familiar with the medications, their names, and what they are. So if minimum, know this screen. Know that if I tell you your patient is on dopamine, I want you to be able to recognize it as an inotrope. If your patient is on a calcium channel blocker, beta blocker, a dilator, we know that that is going to decrease your blood pressure, decrease afterload, and your vasoconstrictors, vasopressors. Those are just basically because we're in advanced critical care. We're not going to give these really to heart patients unless we really, really need to, because they're going to cause tachycardia as well, and that might not be something that we want. We use those carefully. But these are our vasoactive medications, so I would like you to be comfortable with these names and their purposes. I do go into detail, and I like this little flow chart. This helped me a lot when I started in critical care. If you're not interested in critical care, you can skip this chart. It's not necessary for the test. But if you like critical care, and I'll probably be using these as we talk a little bit more about sepsis and things like that. This is like our chooser. This is how we choose them. Is, you know, when they're talking about afterload, if you have high afterload, that's the high diastolic blood pressure, we'll give dilators. If we have low diastolic blood pressure, we might give something to help you dilate and squeeze. So I kind of like it. Like I said, it's not important for your test, but it is a nice little symptom chooser. I used this for many, many years during my critical care, so that I would be like, am I choosing the right medicine? And so that's there for you. I would pay attention to this digoxin slide, just because digoxin is such a big med, both for me and for NCLEX and for any cardiac. You probably come across a lot of digoxin questions on your UWorld. So this is basically a drug card for digoxin for you. And I think I'm going to, again, have you just change this. I don't want you guys obsessing. It's not a bradycardia. It can't be digoxin. Any arrhythmia. Would be something that I would be concerned about if the patient is on DIG. Again, these just kind of go through each med, so I'm going to let you take time and learn as much about them. I just really want you to know, when you see dobutamine, I want you to think inotrope helps you squeeze. So I just kind of put all those there, and you can go through them. They're kind of drug cards for each one. And that is the end of the heart failure lecture.